Hi everyone, I'm Dr. Ng here. I'm going to talk to you about maternal sepsis. Sepsis is defined as a life-threatening organ dysfunction caused by dysregulated host response to infection. Here, the host means the patient, herself or himself. And what is maternal sepsis? Maternal sepsis is a sepsis that occurs during pregnancy and puerperal period. And what is septic shock? Septic shock is when there is shock meaning that the patient has hypotension. So when you have sepsis and you require vasopressor to maintain your MAP more or equals to 65 mm mercury in the absence of hypovolemia and a serum lactate of more than 2 millimole per liter. Why is it important for us to learn about sepsis? Because in pregnancy, we know that pregnant woman is at risk of developing sepsis, and it actually causes a significant number of morbidity and mortality to pregnant women, even in their puerperal period. The principle of management is quite simple, which we will use the resusc principle, and it is adopted from Southwell manual. And from these slides onwards, most of the informations are adopted from the latest Southwell manual. You need to recognize what is sepsis. So a patient will not come to you and tell you, see, I have sepsis, but instead they will come with symptoms. All right, so you can look at them. So look at this on my right side. First, you can see they might have tachycardia, they might have weak pulse, they might have fever. This is not necessarily a must for a patient to have fever to say that they have sepsis. Sepsis can occur in patients without fever. So if they come with complaints of shivering, feeling very cold, or they can even come with confusion or disorientation, shortness of breath, extreme pain or discomfort, or they can even come with clammy or sweaty skin. All this you should alert yourself and ask, or would that be a possibility that this patient has sepsis? If you classify according to the system, you will see what are the symptoms that they can have. It is always good to go through a systemic review to find out what is the actual cause of the sepsis, or what is the actual cause of patient being unwell. So central nervous system, they might come with confusion, they might even fit. Respiratory is like cough, shortness of breath, sore throat. Gastrointestinal tract, for example, diarrhea, vomiting, abdominal pain. Urinary systems such as dysuria, pyuria, hematuria, or even a loin pain or back pain. Dermatology wise, you can see rashes, they can have open wound, they can have abscess. In pregnancy, you also need to look for evidence of mastitis. Is the breast engorged or not, and is the wound healed? Okay. And then for reproductive organ, they can come with foul-smelling per-vaginal discharge, or they can even come with excessive per-vaginal bleed, especially those who has secondary PPH or those who has endometritis. Early assessment is important. You need to take focus history, and also you need to do a quick systemic screening through all the system as I mentioned just now. You need to perform a general examination, look at generally how is the patient. Is she ill? Is she weak? All right, and is she pale? Is she being alert or not alert? Okay, all these are in your general examination. Do not just straight away go for vaginal examination, or do not just straight away go to palpate the abdomen. Okay, then after that you need to stratify the risk of sepsis by using the obstetrically modified Q-SOFA score. So for your level, you need to know what is Q-SOFA score. Basically, it involves respiratory rate, altered mental status, and also systolic blood pressure less than 100. So every 2 out of 3 signifies that the patient is at high risk of sepsis and should be resuscitated accordingly and referred to a specialist immediately. And subsequently, you would also want to identify the source of sepsis. As other obstetric emergency, you need to stabilize and resuscitate the patient. And mind you, the RESUS principle, it is not necessary you must go through step 1, 2, 3, 4. It has to be done all together. Okay, so you can call for help. If the patient is impending collapse, you need to call for red alert. And then again, back to the basic DRCAB, danger, response, cardiovascular, airway, breathing. Okay, and you might want to start CPR if patient is unconscious or with abnormal breathing. And you also need to continuously monitor the vital signs, even cardiac monitoring. You need to monitor the blood pressure, heart rate, SpO2 and temperature. And last but not least, you also need to monitor the respiratory rate, because respiratory rate is one of the components of your Q-SOFA score. Then you would want to insert 2 large bore granula. You want to take blood CNS, FBC, DC, coagulation profile, renal function, LFT, serum lactate, VBG, and blood glucose level. So all this is actually investigation, and you want to assess whether there is an organ damage or not. So blood CNS and other CNS is to identify the source, and the rest of behind here is to identify whether which organ has been damaged. And you would also want to monitor the urine output, because it helps to resuscitate the patient later. And if the patient is more than 28 weeks, you would also want to monitor how is the fetus. Urgent management is you perform relevant imaging, such as if, let's say, the patient comes with abdominal pain, you might want to do an ultrasound, or if the patient comes with respiratory symptoms, you might want to do a chest x-ray. And I would like to inform you and remind you that pregnancy itself is not a contraindication for chest x-ray. Okay, you need to refer back to the consent for radiological consent for pregnant lady, which is available in most of the hospital. And there is a consent, and there is a radiation dose. Chest x-ray possess a very, very low dose for pregnant lady, and it is almost negligible for the fetus. And you also want to send relevant samples for culture and sensitivity, and you'll need to carry out this hour 1 bundle. Okay, so this is the thing that you must remember. So what is our hour 1 bundle? First, you measure the lactate level, and then subsequently you obtain blood cultures before administering antibiotic, and subsequently you want to administer broad spectrum antibiotic. You also want to give fluid resuscitation. You give 20 ml per kg crystalloid for hypotension or lactate level more than 4, or when your MAP is less than 65. MAP less than 65 means the patient is hypotension. So last time we used to say 30 ml, but in pregnancy now we have revised it to 20 ml per kg, because we doesn't want to cause patients to have acute pulmonary edema. And the fifth thing that you need to do in our 1 bundle is apply vasopressor. Vasopressor in the first line for pregnancy will be noradrenaline. Okay, so if, let's say, you have measured the lactate level, you have obtained the blood culture, you give antibiotic, you give fluids 20 ml per kg if the patient is hypotensive. But despite giving the fluids 20 ml per kg, patient still hypotensive, then you need to start noradrenaline. Okay, so if, let's say, the lactate is more than 2 but less than 4, you need to monitor the patient closely, because they can tip over very fast. So you would need to remeasure the lactate. What do you need to do subsequently? You have resuscitate the patient, you have give boluses of fluids, you have start antibiotics, you have already start on noradrenaline, for example. Then you need to refer and transfer the patient to a specialist hospital with escort. Okay, so when you transfer the patient, you need to monitor the vital signs every 15 minutes and also the urine output. So what do you do if you are the receiving end? Then you need to involve multidisciplinary team, such as ONG team, medical team, NS, ID, and etc. that is indicated. The patient might need to go to ICU or HDU. You also need to monitor the organ dysfunction. So how do you monitor organ dysfunction? Basically, most of the time we look into the blood. So meaning that you need to repeat liver function, renal function, maybe 6 to 12 hourly or even daily. And then subsequently, you also want to monitor other things such as urine output to look at whether the patient has renal impairment or not. Okay. Then you also might want to decide whether the patient need to deliver or not, but this will be decided by the specialist or consultant. Whether you want to give steroids or not, it also depends on case-to-case basis. So, but for your level, you need to know from number 1, recognize. You need to do an early assessment and then re-stratify the patient. And then subsequently, you need to stabilize and resuscitate the patient. Then you need to do your urgent management, which is your hour 1 bundle, the 5 things that in the hour 1 bundle. And then subsequently, you need to refer to a tertiary center. So as for choice of antibiotics, so I will leave this on the slides. It depends on what are the causes, and it will change from time to time depending on the recommendations from the hospital or from the ministry. So it also depends on whether there is any resistance or not. Okay, so these are the common problems that we see, and those are the common choice of antibiotics. All right, that's it. Thank you for your attention.